I think we close it. Okay.
Hi, students. Good evening and welcome to this class on INICET as well as the previous AIMS question paper. I think you have already a good session with Professor Pushpakini Madam. Now I'll be taking you to the next 1 hour with the neonatology related question paper, which has been asked in the previous exams in the INICET as well as the AIMS and few relevant the entrance exams. So, good evening, everyone. And I also request you can put your questions in the chat box as I'm going through the question paper as well as the discussing some of the important topics which is asked in the previous exams. And if you have any clarifications also, feel free to write in the chat box. The first thing here, could you identify who this right side person is? So you know that the windows are there. We know Bill Gates. Who's the next person next to this? Anyone? Dr. Jane, Dr. KK, Ketan Bhagat. So his name is Bill Keenan. So his name is Bill Keenan. He is called as father of neonatal resuscitation program. Both are Bill, but the next person is Keenan, is very popular, and he has for the last 4 decades has trained millions of people in this field in the neonatology, specifically for the neonatal resuscitation program. So with this question, let us go to the uh, first question. In neonatal resuscitation, which of the following is the most effective indicator of successful ventilatory efforts? Answer is B. Very right. Dr. Jain, you've written already the rise in the heart rate. So the two important parameters which we use for the successful resuscitation in neonatal resuscitation program is while giving a bag and mask ventilation. One is a chest rise, and the second is the increase in the heart rate. But remember, the increase in the heart rate is the most specific and most accurate indicator, tells us that we are resuscitating the neonate correctly. So this is I just go through the basic resuscitation. This is the basic, the 2020 edition of NRP, and there we are going to ask only 3 questions. Remember, term gestation, a good tone, a baby is breathing. And for all this question is answer is yes, which means that we need to do a delay cord clamping, that is roughly about 1 to 3 minutes, and then deliver the baby, especially on the mother's abdomen in a normal vaginal delivery, and then start a skin to a skin contact as well as a breastfeeding, which means that this is called as the routine care. So if any of this question answer is no, which means that the baby should be started with something called as initial steps of resuscitation. And these steps are: first is warming the baby, drying the baby, positioning the baby, suctioning the baby, and stimulating the baby. For stimulation, we do a very gentle rubbing the back of the baby, or maybe just flicking the sole of the baby. And with this methods, next we go to assess the baby with the 2 parameters. As I mentioned, one is the respiratory rate, second thing is heart rate. My question for the students who are there: how long we assess the heart rate and respiratory rate. It is for only 6 seconds. So 6 multiplied by 110 gives us roughly the respiratory rate and the heart rate for 1 minute, which means that the baby's respiratory rate is about 3 in 6 seconds, which is 30 is the respiratory rate, and baby's heart rate is around 6, which means that baby's heart rate is 60 per minute. So this is the very simplest way of assessing the neonate at birth for resuscitation. And next, once we know that the baby is not breathing or crying, or the baby's heart rate is less than 100 per minute, we go for what is called as bag and mask ventilation. In fact, the bag and mask ventilation is one of the most effective steps of a resuscitation, and we can resuscitate with this the method many babies. And if anyone knows the steps of giving a correct bag and mask ventilation, we can successfully resuscitate the baby. And then simultaneously we can connect the pulse oximeter for the right hand. Right hand is always the predactyl and gives a saturation. I'll show the saturation trends subsequently. And this is what is called as basic steps of resuscitation. 1 minute, golden minute, we should initiate the resuscitation or breathing in this baby. Suppose the baby's heart rate remains less than 100 per minute, which means that we are not successful with bag and mask ventilation. We can do a corrective steps, bag and mask ventilation or ventilation corrective steps. What is the corrective steps? Anybody in the group can answer? We call it as MR SOPA, which means that you take up the first two steps. MR is a mask adjustment and reposition, and give a 5 effective breaths, and then go quickly for suctioning. If still there is no increase in the heart rate or increase in the chest rise, go for suctioning, that is open mouth, and then open mouth, and then give 5 breaths, again 5 breaths. But still baby's chest rise is not there, increase in the heart rate is not there, and then we can go for the increase in the pressure and the alternative airways. So this is what is called as the ventilation corrective steps for a bag and mask ventilation. And most of the baby will respond with this ventilation corrective steps. As I mentioned, remember the saturation. Two signs I mentioned: respiratory rate, second is heart rate for 6 seconds, and third is pulse oximeter. Remember that the saturation at birth is 1 minute is 60 to 65, by 5 minutes is goes up to 80 to 85, and by 10 minutes is around 90 to 95. To reach the 90 to 95 saturation, baby takes at least 10 minutes, and this is a natural process. Don't expect the baby to have a 90 to 95 saturation at birth. And subsequently, still we are not successful with ventilating the baby, we go for a endotracheal intubation or endotracheal tube insertion. And then if the baby's heart rate remains 60 to 80, 60 to 100, we can continue the bag and mask ventilation. Whereas if the baby's heart rate drops down a less than 60 per minute, in this situation, we give intubation, as well as this is the intubation, chest compression with the 100% oxygen. And then we continued for 1 minute. Every 30 seconds, we assess the baby initially the basic steps for heart rate and respiratory rate. But once we go for our intubation, insertion of endotracheal tube, and chest compression, we are not going to do the 30-second assessment. We're going for a 1 minute assessment. So remember, 100% oxygen is required for a chest compression. And then subsequently, if still heart rate remains less than 60 per minute, we use a adrenaline, IV adrenaline for a baby for further to improve the heart rate. And this is how the baby could be resuscitated. And this is called as the advanced steps of resuscitation. So, going to the next question. So, what is the ideal route of drug delivery in neonatal resuscitation? I have already mentioned. The students can answer intraosseous, umbilical vein, the peripheral vein, endotracheal. So, what is the answer? It is the umbilical vein, not the peripheral vein, umbilical vein, because that is a central venous access. We can put the umbilical vein catheter to the umbilical vein. There are three vessels are there, two arteries and one vein. So we can insert the umbilical vein and use a 1 in 10,000 strength of a adrenaline. What adrenaline is available in India is 1 in 1,000. So we have to dilute it 10 times to make it 1 in 10,000. And this dose is about zero point 0.3, so zero point 0.1 to 0.3 ml per kilo is used for the umbilical vein, through the umbilical vein, and then followed with a zero point 0.5 ml to a 1 ml of a normal saline infusion. So suppose umbilical line is not inserted, and if you are using a endotracheal route, so what is a drug constant, what is a drug dose is used for adrenaline? So here adrenaline in the endotracheal route, we use zero point 0.5 to 1 ml per kilo through the endotracheal route. So this is the way we use the adrenaline. Remember, only one drug in newborn resuscitation, that is adrenaline. And as I mentioned, two signs, heart rate, respiratory rate, added with the pulse oximeter, third sign. So we'll go to the next question. Administration of a IV adrenaline is considered in neonatal resuscitation under the following situation. Heart rate between 60 to 100 beats per minute with effective compression and ventilation. Heart rate is less than 60 beats per minute with effective compression and ventilation. Heart rate is not improving even after 30 seconds of effective compression and ventilation. Heart rate not improving after 60 seconds of effective compression and ventilations. So what is the answer here? So the answer is B. So I hope all of you are listening. I just covered up. So the heartbeat is less than 60 beats per minute with effective chest compression, ventilation with 100% oxygen. Then only we can use the adrenaline. So this is a basic about the neonatal resuscitation, and there are a lot of questions being asked in this topic, and this is sufficient to answer most of the questions. Now going to the another set of questions. A baby is born, newborn baby, and assessed at 5 minutes after birth, and baby is found to be cyanosed with gasping respiration. Heart rate is 60 beats per minute. No response to stimulation. Now the question is here, what is the Apgar score of the baby? Which is answer A, B, C, D? Anyone? Quickly? Or difficult to answer this question? So somebody's mentioned is answer is A. That is the answer is that is the 2, which means that I'll go back and let us see here. Apgar score, I know it's little difficult Apgar score, but in the exams are being asked it very frequently. 5 component, appearance, skin color, cyanosed 0, whereas cyanosis at the extremities score is given a 1, whereas a baby is pink, the score is given 2. The pulse 0 is 0, less than 100 is 1, more than 100 is 2. The grimace, the reflex irritability. So no activity at all, 0. So weak cry is there. We can give a score of 1, and good cry we can give a score of 2. Activity tone of flaccid, given a score of 0. Some flexion is there, given a score of 1. And good flexion is there, given a score of 2. Respiration, no respiration, 0. Whereas the irregular gasping respiration, his score is given 1. Whereas a good respiratory effort score is 2. So what is the answer now? Anyone? Somebody has already answered. A. A is a right answer. That is, I go back to the question. So this is the gasping respiration. Heart rate is 60 and no response to stimulation. So I will expect that possibly no activity also, which means that this baby's score is 2. So the correct answer is 2. A little tricky this is, and we need to go through this quickly in a few seconds of time which is given. Sometimes difficult to answer, but if you are ready with your the background knowledge, you can answer this question very easily. A word about the Apgar score. All of you know Virginia Apgar. She's an anesthetist who devised the score. Maximum is 10. All score is taken at 1 minute, 5 minutes, then multiples, 10 minutes, 15 minutes. So any score more than 7 is normal. Any score 5 to 6 at 5 minutes, we call it as mild birth asphyxia, not at 1 minute. And any score less than 3 at 5 minutes, we call them as a moderate birth asphyxia. And any score less than 3, we call it as severe birth asphyxia. So this is based on the Apgar score. We use this classification. But this is what is meant. Remember, Apgar score is not used for initiate resuscitation. Apgar score is used to prognosticate the baby who has resuscitated. Again, 1 minute, 5 minutes, 10 minutes score. The score of 0 to 3, remember, it indicates a severe difficulty in making the transition. Or as I mentioned, anything between 3 to 5 is moderate asphyxia, and anything less than 3 is a severe asphyxia. And these babies requires to be admitted in a intensive care unit and managed in the neonatal intensive care unit. So, as per the American Academy of Pediatrics, as well as the American College of Obstetrics and Gynecology, to define what is called as perinatal asphyxia, or the other term which is called as hypoxic ischemic encephalopathy, which means that we need to do a umbilical cord pH and the artery pH, which gives the exact acid base nature of the fetus, less than 7 at birth, or Apgar score less than 3 for more than 5 minutes, or a baby showing immediately after birth encephalopathy. And these are the characteristic features of encephalopathy. Babies having seizures, or stuporous or comatose, or baby is hypotonia. If these features are there, possibly we're dealing with a perinatal asphyxia with hypoxic ischemic encephalopathy. Whereas baby had a low Apgar score and subsequently Apgar score has improved, but no encephalopathy features, and such babies, we label them as perinatal depression. So there's a difference between the perinatal depression, perinatal asphyxia. Asphyxia means hypoxia. Hypoxia means ischemia, and hypoxia ischemia leads to a acidosis. That's the reason the pH is low in this baby. And subsequently, that is, these babies are prone for multiple organ involvement, and mostly, as I mentioned, one is here The CNS involvement will be there, the acute kidney injury will be there, a liver injury will be there, and myocardial hypoxia, and so many other organs being affected in this. And this is a complete sequelae of a perinatal asphyxia with hypoxic ischemic encephalopathy. This is another staging which has been used to prognosticate a asphyxiated baby. I'm not going to the details. They are called as Sarnath and Sarnath staging based on of 5 parameters. There is a level of consciousness, the neuromuscular control or tone of the baby, reflexes in the baby, autonomic function, that is tachycardia, bradycardia, the pupil size, excessive salivation, and the seizures. And based on that, we classify them stage 1, 2, 3 for mild, moderate, or severe. The moment the baby is having a seizure or following a resuscitation, remember that this baby has got a moderate encephalopathy. So, why this classification? Because this is again necessary for us to counsel the parents that how we should, the prognosis of this baby will happen subsequently when we manage these babies in the neonatal intensive care unit. Mild or stage 1 encephalopathy means maybe a little alert baby, little excessive crying, some changes in the tone, otherwise absolutely normal. And such babies, disability is zero, as well as the chances of death will be a zero. Whereas moderate encephalopathy, remember that as I mentioned, change in the sensorium, as I mentioned here, change in the sensorium, tone will be flaccid, maybe a increased tone also, reflexes will be brisk, autonomic function here, the pupil will be a meiosis will be there, and seizures will be there. And this babies, when we talk to the parents, chances of death even after treatment is around 6%, whereas this baby has got a 30% chances of a disability. A severe category, that is a stage 3 of HIE, whereas a stuporous baby, there's a flaccid tone, reflexes are not elicitable, newborn reflexes, that is the sucking, swallowing, morose are not elicitable, and they may not be a seizure, plus autonomic dysfunction, that is the dilated pupil, not reacting pupil, excessive secretion, and babies depend on ventilator. Such category we call it as a severe asphyxia. The chances of death is 60%, and chances of the long term, the survival of this baby will have a 100% mortality. So, with this basic covering, let us go to the another important topic, and which is most commonly asked in most of the competitive exams. So, what is the most common cause of a neonatal respiratory distress syndrome? Answer is maternal hypertension, premature birth, maternal diabetes, and genetic factors. What is the answer, students? I hope you're listening. So somebody's answered the premature birth. Anyone is answering any other question? Any other answers here? Is it a difficult question? Again, the respiratory distress syndrome. This is also called as surfactant or deficiency, commonly seen in a preterm baby and particularly less than 34 weeks of gestation. But even 34 to 37 weeks, that's called as a late preterm, we sometimes we see RDS. So this is the situation. So maternal diabetes can increase the risk of RDS. We see maternal diabetes, genetic factors, whereas a decreased risk of RDS we see in a gestational hypertension, maternal hypertension, pregnancy induced hypertension, eclampsia, preeclampsia, in this situation. The another situation where increased RDA is seen in a babies with the twins. Suppose again a growth restricted babies is there, again which is a protection because the baby is already stressed inside the uterus. As a result, cortisol is produced and the cortisol can help in production of the surfactant. So it is the type 2 alveolar cells which produces the surfactant. And the surfactant is one of the important drug which we use in a newborn babies, and specifically with the preterm babies with the RDS. And the last 3 decades or more than 3 decades, this surfactant installation and this drug is given to the endotracheal route at birth, or maybe within the first few hours after birth to the babies, which protect the babies against the hyaline membrane disease of surfactant deficiency. So now there's another drug which is very useful, which is given antenatally. So what is a drug which is given antenatally? Anybody can answer this question? And what is the dose of this drug is given and which protects as well as the decreases the risk of RDS being in the newborn babies? Magnesium sulfate, somebody's written, is not the magnesium sulfate can help in the neuroprotection, but one more important drug, the something called as antenatal steroids. I hope all of you are know about antenatal steroids. So preterm, we always give antenatal steroids, and here we use a dexamethasone or betamethasone. Easy to remember. Betamethasone is most commonly used in the dexamethasone, and the dose is betamethasone is 12 mg q 12th hourly, 2 doses before 24 hours of a delivery. Whereas dexamethasone, 6 mg every 6th hourly because of a short half lifespan at 24 hours before the delivery. Easy to remember, 24 milligrams of a dexamethasone or 24 milligrams of a the betamethasone should be given 24 hours prior to the delivery, can help in the the surfactant production and decreasing the risk of the severity of RDS. Magnesium sulfate is a neuroprotector which helps in the prevention of a bleed and this baby developing into the IVH or the periventricular leukomalacia can be benefited. And again, dexamethasone is useful only from 24 weeks to a 34 weeks of a gestation. Ideally, 24 to 32 weeks may be extended to a 34 weeks of a gestation. Whereas the magnesium sulfate, again 24 weeks to around 32 weeks of a gestation can be given. So anybody remembers what is a dose of magnesium sulfate given for a neuroprophylaxis? And all of you know that magnesium sulfate is used in a eclampsia or preeclampsia. The dose of magnesium sulfate used for a neuroprophylaxis is 1 gram per hour as a loading dose given in the first 4 hours, and then a maintenance dose is being given there. So this is the dose. There may be a changes are there because there's a lot of changes are happening in the last few years. So this is earlier given the dose of a magnesium sulfate. So with this, let us listen to this. Go to this question. Which of the following is the most appropriate initial management for a preterm infant with respiratory distress? Answer is mechanical ventilation, administration of surfactant, oxygen therapy, continuous positive airway pressure. So anyone is using what answer here? So what is the answer? the most appropriate initial management for a preterm infant with respiratory distress? Nobody is answering. The answer is continuous positive airway pressure. So somebody has mentioned answer is two. That is the Sujata. Good answer. So the reason CPAP, this is also called as peak end expiratory pressure. As I mentioned, surfactant deficiency, we have a multiple alveoli are there, first of all in the babies. And these alveoli are covered with something called as surfactant. And the action of this surfactant is to prevent this alveoli being preventing from collapse. Now, when the surfactant is absent, this alveoli collapses. As the collapses, this lung goes into a atelectasis. And this leads to a proteinous exudate into the alveoli and forms a very thick membrane over the lung. And that's why it is called as hyaline membrane. Now, the use of a CPAP, that is a use of a PEEP, will help to prevent this terminal alveoli from not collapsing. So as a result, it produces what is called as functional residual capacity. So, so the simplest, easiest way, if there's a preterm births are there, I have mentioned earlier in my class bag and mask ventilation, but here bag and mask ventilation can be used with a PEEP wall or CPAP, or this equipment is also called as a flow inflating bag, or also called as TP's resuscitator. So this is used for resuscitation purpose, which gives a PEEP, prevents the collapse of the alveoli, and you can transfer the baby with this to the neonatal unit and then connect to the ventilator, and then you can consider for giving the surfactant administration. A very good history about the surfactant. Somewhere in the 1963, the Patrick Kennedy, John F. Kennedy's son, he was born at 34 weeks of gestation, I think around 2.4 kilo baby, and he was died within 2 days because of the surfactant deficiency. And those days, surfactant was not there. As a result of this, a lot of money has been pushed into a research, and we had a novel drug presently called as the surfactant. And this surfactant we produce from the bovine, that is the cow, as well as the porcine, the pig lung extract. So the bovine lung extract, what we call it as a baractant, which is available, and these are the natural surfactant. This is produced from the cow, whereas poractant is from the porcine. So, and this is purified and put into the baby's lungs. Now, what is this surfactant consist of? Surfactant consists of a phospholipids, consists of a neutral lipids, fatty acids, as well as the surfactant protein A, B, C. And this is used. Remember two things which I mentioned so far. One is the newborn resuscitation. Second thing is the use of a surfactant, which has improved the quality of life of a neonate as well as the salvaged millions of the babies across the globe. And this is what we call it as surfactant replacement therapy. So now one more question here related to that, which is asked in the previous exam. Correct about the respiratory distress syndrome is seen after 6 hours of birth, overproduction of surfactant, more commonly seen in term neonates, the air bronchograms seen on a X-ray of a chest. So any answers here? Any? The answer is very good. The again, uh, the Sujata as well as many people have answered this uh, question. That's the air bronchogram on the X-ray chest. If you see here, these are the X-ray. This is the first X-ray of a baby with a respiratory distress syndrome, and this is a classically a white out lung. And you can see here, we cannot differentiate the cardiac borders from the lungs, and the lung volume is less. This is what I mentioned earlier. Just put a little peep here. That is the functional residual capacity, which helps in preventing alveoli collapsing and then benefits. Second thing is we can use directly administration of a surfactant. Whereas here, this is another extra. This is a very severe form of a RDS, whereas this would call it as mild to moderate RDS. And here you can see the lot of air bronchogram plus reticulogranular pattern. So remember, three distinct characteristic features of the babies on the lungs by RDS is as whiteout in a severe grade, air bronchogram or reticulogranular pattern in the baby's mild to moderate RDS. So anybody can answer this third X-ray. What you think this X-ray? Is it a RDS X-ray or is it something else? As I mentioned by RDS, the cardiac borders are not clear. Here the cardiac borders are clear. We are not seeing any whiteout appearance, uniformness, which is we are not seeing here, but we see here haziness on the right upper lobe. And this is seen at birth. And this X-ray tells us possibly we're dealing with congenital pneumonia, and this is not a RDS. So remember, this is not a uniform, only one lobe of the baby is involved. So this is the congenital pneumonia X-ray, whereas the other two X-rays are the RDS X-ray. So little lengthy question. These questions are generally not asked in the competitive exams, but this has been asked. 3.5 kilo male infant born at term after an uncomplicated pregnancy and delivery develops respiratory distress shortly after birth and requires mechanical ventilation. Chest radiograph reveals a normal cardiothymic shallot but a diffuse ground glass appearance to the lung field. Surfactant replacement fails to improve gas exchange. Please remember here, surfactant replacement fails to improve the gas exchange. Over the first few weeks, the hypoxemia worsens, results in results of a routine culture. Echocardiographic findings are negative, which means that we are trying to rule out the cardiac problem. We are trying to rule out the congenital pneumonia, and also, there's a history that a term female sibling died at 1 month of age with respiratory distress. So, which of the following is likely diagnosis? So, anyone can answer. The A is total PVC, B is meconium aspiration, C is neonatal pulmonary alveolar proteinosis, D is disseminated herpes simplex infection. Somebody's answer C, neonatal pulmonary alveolar proteinosis. Anomalous pulmonary venous return is not a correct answer. Meconium aspiration, again, not a correct answer because there is no history of a meconium at all in this baby. Disseminated herpes simplex infection, we should have some history to say that. Plus, added to that, a female sibling has been died earlier. The correct answer is neonatal pulmonary alveolar proteinosis. Now, what is this neonatal pulmonary alveolar proteinosis? This is nothing but is an abnormal accumulation of a surfactant derived lipoprotein in the alveoli. Very rare condition. Generally, we don't see, but something which is mimics a very close to a pulmonary alveolar proteinosis, and we keep seeing once occasionally is something called as a surfactant, a protein, a B or C deficiency. So remember this. So it could be next, this answer could be changed to either surfactant protein B or protein B C in deficiency. Uh, s- Some Sujata has asked, do culture negative rule out meconium aspiration? Yes, meconium is always sterile. Remember, meconium is the first stool which baby passes inside the uterus and which is mixed up with the which with the amniotic fluid. Only if a preterm baby passes meconium, that could be a cause for infection, and listeria is the organism. Suppose this question is asked as a preterm baby passed meconium in utero and then developed the respiratory distress and subsequently baby died, uh, could be a listeria, could be the organism again, which is a gram positive organism, listeria. So preterm baby, meconium, remember listeria. Term baby, meconium is passed in utero, is always the asphyxia, or it could be a post-mature baby. So with that, we'll move on to the next set of few questions. Which of the following is not a common symptom of a neonatal sepsis? Fever, poor feeding, bradycardia, increased activity. A very common question and very common findings we keep seeing in a newborn babies. Increase activity. Somebody has mentioned. I think many of you mentioned the increase activity. Yes. So we expect a decrease activity in the baby. So the other clinical features of a sepsis, remember fever is not always there. Fever may be a common manifestation in the first after first week, whereas hypothermia is seen a babies with a neonatal infection in the first week. The first 3 days infection, we call it as early onset neonatal sepsis, whereas more than 3 days, we call them as a late onset sepsis. So here, the early onset classically is by the maternal genital tract organisms, whereas the late onset, it is the either community infection or it is also called as the health care associated infection, HAI, high we call it as. Here, the maternal genital tract infection, remember, E. coli is the most common organism, or it could be a organism which present in the genital tract. Whereas the late onset, the classical is the community acquired is always the staph aureus or staphylococcal group of organism, whereas the HAI, it is the gram-negative bacilli, Klebsiella, Acinetobacter, Pseudomonas, so on, will be the HAI. So here, as I mentioned, hypothermia is one of the finding. Fever maybe then the second weeks and decreased activity we see here, bradycardia may be there, but we see tachycardia. Heart rate is more than 160. Normal heart rate has been neonates is 120 to 160, but here it is more. Poor feeding, baby is not tolerating the feeds. And sometimes in the late stages, we see a thickened skin, and this is called as sclerema. Sclerema has appeared in the baby, which means that baby is already gone into an infection. Early onset infection, remember this baby is goes for a congenital pneumonia, whereas late onset infection, the commonest manifestation is meningitis. Except one situation, which I not covered up here, was a group B streptococcus, GBS, or group B streptococcus is one of the very fatal organisms in the early onset sepsis, can lead to a meningitis also and very bad mortality. So here the next question, most common cause of neonatal sepsis in in hospitals in India is most common cause is E. coli, Klebsiella, Staph aureus, Listeria. So somebody's answered E. coli, somebody's answered Staph aureus, but I would say this is a hospital acquired infection. As I mentioned, hospital acquired infection, HIE or short form. As I mentioned in my previous thing, it is a gram-negative bacilli. Commonly, it is the Klebsiella. E. coli is a early onset neonatal sepsis. Staph aureus is a community acquired. Listeria monocytogenes is again seen not so frequently, whereas in India, Klebsiella and Acinetobacter, they are the most common causes of hospital acquired infection in neonates. So the answer is a Klebsiella. So with this set, let us go to the another last set, and possibly this could be the last set which I'm going to cover up, or if there is a time permits, I may run a few questions very quickly. Ductus dependent blood flow is required for all of these congenital heart disease except persistent truncus arteriosus, hypoplastic left heart syndrome, pulmonary stenosis, transposition of great arteries with intact ventricular septum. Ductus dependent blood flow is required for all of these, which means that we need to keep the ductus open. So, anyone answer here? C, somebody's mentioned pulmonary stenosis. C is not the right answer, except it is. So, whereas TGA with intact ventricular septum, we require a ductus. Hypoplastic heart syndrome, we require a ductus. Pulmonary stenosis, we require a ductus. Whereas a persistent truncus arteriosus is the right answer that do not require a ductus. So I will discuss these things. This has been already, madam has been covered up. I'm not going to cover up. So we know that a two group of disease, of cardiac disease, is cyanotic and cyanotic. In this cyanotic, we have increased pulmonary blood flow group and we have a decreased pulmonary blood flow group. So, which is the decrease pulmonary blood flow group? Anybody can answer this question, which has been already covered here. Decrease pulmonary blood flow. You can remember right ventricular outflow tract, right ventricular outflow tract obstruction. So what are the things comes in the right ventricular outflow? One is pulmonary stenosis. Second thing is tricuspid atresia. So these are the decreased pulmonary blood flow groups. Okay, and pulmonary stenosis always seen in tetralogy of Fallot, whereas increased pulmonary blood flow is seen in the conditions like the increase as uh, the truncus arteriosus as well as the TGA. We can see sometimes the increased pulmonary blood flow group, okay, as well as the total anomalous pulmonary venous circulations, okay. So these group where is decreased, as madam has clearly mentioned, they are oligemic full. Decreased blood flow, oligemia. Increased blood flow, plethora. Okay, remember that. So wherever the decreased blood flow is there, which depends on the ductus, and this is called as a pulmonary ductus dependent circulation. Whereas, so you can remember any of those right out ventricular outflow tract. Whereas a systemic ductus dependent circulation are classically, anyone can answer, which is a systemic ductus dependent circulation. I will going to explain it next slide. If anyone knows, can answer this. They are classically coarctation of aorta as well as the hypoplastic left heart syndrome. We call it as HLHS. So I just briefly cover up. This is the most commonly again asked the questions regarding the etiology for a, or risk factor for the congenital heart disease. So lithium, which is one of the drug used antidepressant. So all of you know that what disease, what cardiac problem it causes. Can write in the chat box. Meantime, the another disease which present in the mothers called as phenylketonuria. Epstein's anomaly is the right answer. Whereas phenylketonuria, there is a spectrum of diseases are there, which could be a coarctation of aorta, retrology of Fallot, PDA, hyperplastic left heart syndrome, VST, and so on. Insulin dependent diabetic mother. What kind of a cardiac problems you can expect? So thank you very much. Somebody has corrected me. That's lithium is a mood stabilizer. I mentioned as antidepressant. Thank you very much for correcting me. So IDDM, what we expect, insulin dependent diabetic mother, we can expect sometimes TGA, that is during the organogenesis stage, or at later stage, we can get a septal hypertrophy in the babies, and which will get corrected over a period of time. Mother having systemic lupus erythematosus, SLE. So what problems you expect in a baby's heart? Anybody can put in the chat box quickly. SLE can lead to conduction defects in the baby's heart or bradycardia. As I mentioned earlier, tachycardia is very common, whereas bradycardia is less commonly seen. So lupus babies are born with the sometimes with the conduction defects. The rubella infection in the mother. What kind of a cardiac problems you expect? Satakshi has mentioned heart blocks. Correct answer for a SLE. Rubella, what kind of a cardiac defect you expect? So the rubella we expect again could be a PDA, VST, so on. But peripheral pulmonary stenosis, a more specific answer for rubella. Then you know that the lot of chromosomal defects are there. Trisomy 21. Anybody can answer. What is the most common cardiac defect in trisomy 21? Any answer for trisomy 21? Then maybe a trisomy 18 as well as the trisomy 13. VST is PD, VST somebody has mentioned. VST is present. I won't say no, but if you the competitive exams, it is a specific answer they asked. It is the endocardial cushion defect. That is the most specific cardiac anomaly related to a trisomy 21, whereas trisomy 18, that is called as Edwards, trisomy 13, Patau, we can get again whole spectrum of a problem, VST, AST, PDA, Radiology of Fallet, hypoplastic left heart syndrome, and so on. Di George, again, very commonly asked question. This is Di George. What do you expect here? Cardiac problems. And what is Di George is associated with? This is also called as 22q11 deletion. This is also called as the name says, 22, catch 22, the name. So discharge, the cardiac problem is truncus arteriosus, and one most common electrolyte problems seen here is hypocalcemia. So the another reverse of a discharge, we call it as Williams. So what is the cardiac problems associated with Williams? It is the aortic stenosis. And what electrolyte problems associated with Williams? KK as well as the Nafis has mentioned hypocalcemia. I hope it is the Digeorge syndrome answer. Yes, but for Williams, other than the aortic stenosis, the reverse of hypocalcemia, that is the hypercalcemia. So remember, there's a lot of questions, opportunities are there in this chapter to ask about. And these are the most common questions being asked in the most of those competitive exams. So here, with this little background, let us go very quickly and try to finish maybe in the next 5 to 10 minutes. A child admitted on 7 days of life with severe respiratory distress and shock. He was discharged 2 days back, healthy. What could be the probable diagnosis? VST large, hypoplastic left heart syndrome, Epstein anomaly, aortopulmonary window defect. Any answers here? Shock. This baby is presented with a shock. Shock means which one you think here? VST large? Do you think can cause? No. What about the hypoplastic left heart syndrome? Yes, that's the right answer. Epstein anomaly do not causes. Aortopulmonary window do not causes the sudden so shock and death. So any newborn baby comes with possible cardiac problems, died within the first few days, hypoplastic left heart syndrome, or sometimes transposition of great arteries, TAPVC, or coarctation of aorta. So this is also present with the uh, coarctation of aorta with the defect in the systemic perfusion. So if you see here, the first picture is the coarctation of aorta. As I mentioned earlier, coarctation of aorta, sorry, the truncus arteriosus, this is, and this is a common ventricular septal defect. There's a blood flow is present for the lungs. So this is not dependent on the pulmonary, the dependent on the ductors. This is a classically, the picture is hypoplastic left heart syndrome. You can see the left atrium is smaller, left ventricular is smaller, and the ascending part of our aorta also smaller. So remember, this defect can lead to a cardiac death. I mean, the neonatal death due to cardiac cause in the first week itself, because any blood is not going through the systemic circulation. Only way to keep this baby surviving till the surgical option is, this is the ductus, we call it as patent ductus arteriosus. We need to keep it open, and the drug is used to keep this open. Generally, the patent ductus arteriosus or ductus arteriosus closes within 24 hours, maybe physiologically 48 to 72 hours. So, what drugs we can use to keep this ductus open? I mentioned pulmonary dependent PDS ductus circulation, systemic ductus dependent circulation. So what drug we can keep it here to keep this ductus open? And the next one here, the third situation, we have a parallel circulation. This is the where the aorta arises from the right ventricle and pulmonary artery arises from the left ventricle, and this is called as transposition of the great arteries. Anybody can answer this question? What drugs we use keep the ductus open? Can put in the chat box. I know all of you are tired. Maybe another few minutes I'm going to cover up and wind up the session. Ibuprofen and indomethacin, somebody has mentioned. Ibuprofen and indomethacins are used to close the ductus in a preterm baby. So not to keep the open the ductus. Any other answer? And this is we usually give us an infusion till we do a surgical interventions in this babies. So it is the prostaglandin E1, PGE1. This is available as Prostin as a trade name, and this is drug we use to keep the ductus open till the surgical correction is done, because this is when we keep this ductus open, the systemic circulation takes place here. The TGA, again, there is no pulmonary circulation at all. Unless we keep this ductus open with the prostaglandin, then till the surgery is done, this baby could be survived. Or sometimes we do in an intact atrial as well as intact ventricular septum, we do atrial septostomy, and this is called as Ruskin procedure, septostomy, which is emergency procedure, so that we are trying to mix up the systemic and pulmonary circulation, so that the blood flow takes place to the baby. Or immediately at the earliest, we need to go for a corrective surgery. So, what is the corrective surgery done for a transposition of a great artery? Which means that here we cut it and bring it to the, this is the aortic trunk, bring it to the left side, and pulmonary trunk bring to the right side. Any answers here? So what is the surgery we do for a transposition of a great arteries? Very good. It's called as arterial switch. Satakshi has mentioned that arterial switch. This is also called as a Jetain procedure. Okay. So here we have something, a very common cardiac condition, cyanotic cardiac disease called as tetralogy of Fallot, and sometimes the pulmonary stenosis is a critical factor deciding about the outcome of this babies requiring surgery at the earlier. So if you can see here, all of you know the components of a tetralogy of Fallot. Madam, I think most have covered. I'm not going to cover up. Here, there are a few procedures are there. Pulmonary stenosis. Again, we need to keep a systemic circulation open. This is called as a classical Blalock Taussig shunt. This is a subclavian artery. This is a subclavian artery and connection to a subclavian to a pulmonary artery is called as a classical Blalock Taussig shunt. But problem is that this shunt sometimes get blocked, and which leads to a complication as the baby grows up. So instead of that, presently they do what is called as modified Blalock Taussig, and here they use a material called as Gore-Tex material, which is basically it is the what is called as polytetra. This is material called as polytetra fluorouracil. ethylene polytetra fluoro fluoroethylene material. And this chances of block is less. As the baby grows up, the more flow is goes to the pulmonary artery will be modified by this modified shunt. And these all procedure called as palliative surgeries. They are not the permanent or the final surgeries. Final surgery is correction of the overriding of the artery as well as aorta as well as the correcting the ventricular septal defect. The earlier days, something has been used, what is called as here a water stun stent, which is the ascending part of aorta to the pulmonary artery anastomosis is called as water stuns shunt, and one more shunt called as pod shunt. This is you can see here pod shunt. This is the descending part of the aorta versus the pulmonary artery. Again, these are the questions being asked in your entrance exam. Ascending portion of the aorta and the pulmonary artery, it is a water stance, whereas the descending portion of the aorta as well as the pulmonary artery, it is the pod shunts. So, so this is what has mentioned earlier as a Jetain procedure. The only thing is, accordingly, the coronary arteries also are switched wherever necessary. So, dear students, uh, if you have any clarifications, questions, you can put in the chat box. I will take up. Mostly, I'm not going to go up with the further questions. I have still more questions are there. Maybe difficult to go into the sessions further because you have already tired, must be listening for the last 2 hours, 10 minutes. So, any questions are there which can be put up in the chat box? And whichever the portion which are covered up is not clear also can put up on the chat box so that next few minutes I can pick up these questions and try to cover up your doubts as well as the clarifications. Okay, if there's no further clarifications or doubts, I will end this session. Thank you very much for staying with us and answering very efficiently, and wish you all the best for our forthcoming INICET exams as well as the future exams. Thank you very much.